Hi, everybody, and welcome to today's HHI session. We're going to get started in just a moment, but we do have a few housekeeping items to get through, and I'll get through them as fast as I can. So just be aware you are on. We are recording the session today, so please don't include any confidential patient health information during the discussion or any questions. If you'd like to receive a CME or CEU certificate, you do need to announce yourself here in just a few minutes. You can use the chat box, and I'll type into that in just a minute so it pops up for you. And just let us know who you are and where you're from. Computer video and audio, you are able to mute all those things. It looks like everyone has done so already. We do have a few people on right now, so if you need to unmute, that's typically in the lower left-hand corner of your Zoom screen. Our disclosure and accreditation statements are on screen now. And for some of our other sessions, we do offer case consultations with our expert panels. So if you do have a patient who is a Molina or a Blue Cross Blue Shield patient, you can be reimbursed by those entities. It's up to $150. So it is worth the paperwork to get that done. So get in touch with us if you have more questions on that. You can contact me or Michelle Widener or one of these two people here at Blue Cross and Molina. And now it's time for a roll call. So if you're able to unmute and let us know that you're out there, we'd appreciate it, and where you're from. Looks like we had Philippa Howard just join us. And there's your chat screen in case you need to use that. We've got Melinda Rogers from Loveless Westside. And maybe while we're waiting for that, we could go around the room and introduce our folks in the room.
Okay, I'm Adrienne McConnell. I'm a quality improvement coach here at Envision.
I'm Maya Trujillo. I'm also a quality improvement specialist.
And I'm Erin Marshall. I'm with the New Mexico Breastfeeding Task Force.
My name's Sophie Peterson. I'm one of the OBGYNs with Presbyterian here in Albuquerque.
I'm Emily Sylvesta. I'm a pediatrician and the medical director of the mother-baby unit at UNM and a member on the board of the New Mexico Breastfeeding Task Force.
And I'm Courtney McKinney. I'm the program manager for this initiative called Reducing Breastfeeding Disparities, which is the platform for these telehealth sessions that we're going to be hosting over this next year. So just do it.
And we have Pip Howard, Karen Tapia, Renata Swindle at San Juan, and Renee Coughlin at UNM Prevention Research Center. And yeah, we can go ahead and get started.
Okay, well, thanks everyone for joining us today. We're really excited to have this presentation, implementation of the 10 steps to successful breastfeeding. We have two presenters today that we're going to introduce to you in just a minute. But I just wanted to let you guys know that beyond this live recording, we are going to be recording these sessions and housing them in Moodle. So for those of you who want to view this presentation again, or have colleagues or friends that want to view this presentation, we will we'll have that available for you via our website at Envision New Mexico. So I'll pass it over to Erin Marshall with the task force, one of our partners of this grant, to introduce our presenters.
Great, thank you, Courtney. So I'm Erin Marshall. I'm the acting executive director of the New Mexico Breastfeeding Task Force, and we are absolutely excited to be in this collaborative with Envision New Mexico and able to bring this series of telehealth sessions around maternal health and optimal infant feeding practices. We have today Dr. Sophie Peterson. She is an OBGYN with Presbyterian Medical Group and volunteer with the task force. And also Dr. Emily Sylvesta, and she is a pediatrician with the University of New Mexico Hospital, and as she already said, one of our board of directors, as well as a longtime volunteer with the task force. So I will turn it over to the two of you.
Thank you.
Thanks. Thank you all for having us, and thank you for joining us today. Our presentation is really kind of an overview, and it's primarily geared towards providers who are interested in learning what the baby-friendly path is, and also who are interested in maybe some tricks to the trade, if you will, of how to implement that into either their clinic or into their hospital. So this is my plain language for our objectives today. The first thing we want to do is to explain for everybody what exactly is baby friendly. And as a provider, we would like to explain why you should care and why it's your job. And also, and probably more importantly to some providers, is how do I do it? How do I implement this in clinic? Or how do I bring this into my hospital? Is it going to take a lot of time out of my schedule? We get a lot of questions like that from providers. So here are our formal objectives. We would like to explain the Baby Friendly Hospital Initiative and the 10 steps to successful breastfeeding. We want to articulate the importance of breastfeeding in medical practice. We would like to clarify why providers should promote baby-friendly practices. And we would like to demonstrate some techniques for how to integrate baby-friendly practices into clinical and hospital practice. So the Baby Friendly Hospital Initiative is a program that was started by the World Health Organization and UNICEF in 1991 to encourage and recognize hospitals and birthing centers that offer an optimal level of care for infant feeding and mother-baby bonding. It recognizes and awards and designates birthing facilities who successfully implement the 10 steps, and you're going to hear us talk a lot today about the 10 steps program, the 10 steps to successful breastfeeding, and also we'll talk about the International Code of Marketing of Breast Milk Substitutes. This slide is probably a little out of date, actually, perhaps now.
Pretty close.
We have many hospitals designated now in New Mexico that have been officially designated baby friendly by the Baby Friendly Hospital Initiative in the United States. How many do we have? 8, with more than 8 now though, right?
Well, we have several that are pending designation.
Okay.
And Crown Point is no longer providing delivery service.
Right. So we probably have about 8 and a few more on the way hospitals that are currently designated as baby-friendly facilities in New Mexico. We have, and the Healthy People 2020 goal is to have 8% of hospitals in the United States designated as baby-friendly facilities. And you may hear us refer to the Healthy People 2020 goals again later in this presentation. So what are the 10 steps? Here are the 10 steps to successful breastfeeding as outlined by the World Health Organization. 1 through 10, and pretty clear. Number 1 is to have a written breastfeeding policy. What's that? Each slide. We can do a little, yeah, sure. Okay. The first one is to have, this is just an example that Dr. Sebesta provided us from the University of New Mexico, which is to have a written infant feeding policy that's routinely communicated to all the healthcare staff. If your facility is interested in becoming baby friendly, this is not something you need to reinvent the wheel about. There are policies that have been designed, and the New Mexico Breastfeeding Task Force can help also, but we design a policy that gets implemented through the facility, and this has to be communicated to all of the staff in the facility. Step 2 is to train all of the healthcare staff in the skills that are necessary to implement this policy. Jump in anytime if you want. Step 3 is to inform all of the pregnant women about the benefits and management of breastfeeding. This falls to a lot of the prenatal providers, OBGYNs, midwives, family practitioners, and a lot of this is geared around initiation of breastfeeding. Go ahead.
So this is a handout that we have at the University of New Mexico, and it's called Breastfeeding Your Baby in the First 3 Days of Life. I don't expect for you necessarily to be able to read that, but this is given out actually prenatally by the OB-GYN or the family medicine doctor or the midwife, and then it's given to the mom again after the baby has after the mother's delivered her baby. And the idea is that the more times the mom hears what's normal in the first 3 days of life, the less surprised she's going to be when her 12-hour-old baby is not interested in feeding, and again when her 36-hour-old baby wants to feed all the time. Because parents, it's not intuitive, that your baby's going to be really sleepy for the first 24 hours and then really, really hungry right after that. So we really encourage people to give this kind of handout and give this kind of information prenatally, and then to reinforce it afterwards. We all know it takes several times to learn something.
And at Presbyterian, we have a lot of our prenatal education is designated by trimester. So in clinic, and we'll talk a little bit more about this later, but we have a set of information that we give at the first OB visit. We have another set of information that's given during second trimester, and another set of information that's given during third trimester. So they get 3 different sets of education. There are 3 different educational pamphlets that get handed out to patients in order to fulfill this this step.
We do the same thing, and actually Baby Friendly requires that. They require that the moms have information in each, or education in each trimester of pregnancy. And we're happy to share these handouts. Again, you do not need to reinvent the wheel.
So step 4, this is a really, I think, a really nice, this is maybe kind of overlaps with the other one, but step 4 is help mothers initiate breastfeeding within 1 hour of birth. This is the same thing as step 5, the precious hour or the sacred hour?
This is the sacred hour.
This is the sacred hour. We call this, different hospitals call this different things depending on how they want to market it. But we call this in the breastfeeding world the sacred hour or the precious hour. And this is something that I think a lot of mothers really respond positively to during their birth or immediately after their birth, is not having their baby taken away from them right away. I can't tell you how many positive responses I've gotten from patients, but also after the training and after Baby Friendly has been initiated in the hospital, how much the nursing staff actually really enjoy giving this to the patients as well. So the idea is to help the baby stay with the mom, and also to initiate breastfeeding within 1 hour.
And I'm just going to put in, it says to help moms initiate breastfeeding within 1 hour of birth, but what it really translates to is skin to skin for the first hour, and basically leave them alone. Let the baby and the mom figure it out, because the baby will go through these, I forget how many steps it is, 7 or 8 or 9 steps, naturally crawling up to the breast and latching on if left alone. And if you intervene, they go back to step 1. So you actually don't really want to get in and help. You don't really want to help that much. You just kind of want to put them in the right place and let them do their thing.
And there are some really interesting studies, again, that we'll mention in a little bit, that support this particular intervention also, and how soothing it is for the baby, and how it's a much gentler transition for the baby also. We just talked about skin-to-skin contact, and it's wonderful as an obstetrician or as a delivery provider. This is honestly one of my favorite things, is being now allowed in a baby-friendly facility, is being allowed to deliver and having the support of the staff to deliver the baby straight to mom. It's a privilege that I get to enjoy, but at other facilities I haven't always been allowed to do that, and it's really the ultimate, after the birth you get to hand the mom her baby, and it's wonderful, instead of having to hand that baby off to somebody else. But getting to put the baby skin to skin right away, immediately, and I like to prep moms and tell them that they're gonna, okay, when this baby comes out, I'm gonna hand this baby to you. It's gonna be slimy, and it's gonna be wet, and it's gonna be bloody, and it's all okay. And we have them just expose their entire chest, and we put the baby either right on the tummy or right on the chest immediately after. And the nurses do the vital signs. They do APGARs, they dry the baby, and they do all of their assessment and stuff right with the mother, assuming that the baby is stable.
The nice thing from the pediatrician side is when the baby is skin to skin with mom, they're much less likely to have hypoglycemia. So, for instance, with your infants of diabetic mothers and your small for gestational age babies, it really does benefit them. This really helps reduce the amount of interventions that we have to do and the amount of transitions to the NICU.
And it also, perhaps it's not obvious, but I guess it's obvious. This leads very directly to a really nice transition into that first hour breastfeeding. When you deliver the baby and the baby stays skin to skin, they naturally start rooting, and mothers will notice this, and then it's just an easy transition. So step 5 is show the mothers how to breastfeed and how to maintain lactation even if they're separated from their infants. So again, this is part of this is what we do, is education that we provide prenatally in the clinic, and part of this can be done during the time of delivery or immediately postpartum. There are different parts to this, including hand expression, allowing access to breast pumps, showing moms how to breast pump, and explaining how much they really should be expecting to produce in those first couple of days after delivery. Do you want to add anything?
Yeah, actually, so this is a handout that we give to all the mothers at UNM, and Baby Friendly does require it. It doesn't say in this step, but it is actually required that all moms be shown how to hand express. And I can't, the lactation specialists really rave about this. They say that just by being able to show moms how to hand express, it's very empowering. The mom sees that she has milk. It really can help the mom to kind of prepare her nipple before the baby attaches. It can help the baby who's rooting around. But they really swear by this, and Baby Friendly requires this, so you have to do it. In addition, of course, we're also talking about when moms are separated, because we have a lot of moms who say, well, I had one yesterday, and she said, well, I breastfed my first baby for 1 year, but I'm only going to breastfeed this baby for 6 months. I said, well, why? Well, because I have to go back to school. So then we had a long conversation about, well, how do you get a pump, and how do you pump, and why does this not mean you have to stop breastfeeding at 6 months?
Okay. Step 6 is give newborn infants no food or drink other than breast milk unless medically indicated. This is very important on the mother-baby floors, and although it's not, I think the Baby Friendly Hospital Initiative doesn't include the NICU assessment, but this is also, there is some overlap with NICU care here as well, and the Baby Friendly Hospital Initiative will monitor where formula is kept and how it's kept and where it's stored and how much money you're paying for it. This step, however, I found when Presbyterian transitioned over to Baby Friendly on our mother-baby floor, this really was a culture changer on our mother-baby floor. When the nursing staff at our hospital really embraced this idea, the entire culture changed within that year that we got designated, to where the norm was it changed from the norm being formula fed and that being a very acceptable thing to do, to the norm being breastfeeding. And if you weren't breastfeeding, that was an exception to the rule. And that culture shift really was impressive. It was very obvious to watch happen over that year that we were going through our audits and getting designated.
And a couple of things with regard to this step. So it's don't do it unless medically indicated. And a lot of providers fear that, and a lot of hospitals fear that their doctors are going to get called at 2 in the morning every time mom wants to give a baby formula, and that they're going to get woken up. And this is not the case. So, two things. You end up, as part of your process, putting into place protocols that dictate, for instance, your hypoglycemia protocol, or your weight loss protocol, saying, if baby's glucose is less than 35, supplement with express breast milk, or put the baby to the breast, and then if it doesn't come up, then give formula. So the doctor isn't getting called at 2 in the morning. And the other thing is that you really will have to document. Of course, if a mother insists upon giving her baby formula, we're not going to say no, right? I mean, it's not go over well. But instead of just saying, oh, you want formula, well, here's a 6-pack. Now you have to say, well, why do you want formula? And have a conversation. Well, do you want formula because your baby's not getting enough? Well, let me talk about why this is normal. Or you want formula because you're really tired? Well, let's talk about what this is going to do to your milk supply. So the nurses are required, or the doctors, to give education, and that's documented. And then, of course, if the mother still wants formula, she gets formula. And so it's really important to know with Baby Friendly, we are not forcing people to breastfeed. And all of these steps, by the way, really only apply to the mothers who choose to breastfeed. So if you have a mother who is absolutely planning on formula feeding and she is not going to breastfeed at all, you don't do all this. Okay, she gets to formula feed. And I would suggest that you do what like we've done, which is we've got a little symbol, we have a flower that goes on the door. If the mom either has chosen not to formula feed after she initially wanted to breastfeed, or has never wanted to breastfeed. And so people know when they walk in that room, I'm not going to ask mom, well, why aren't you breastfeeding? And sometimes you can imagine, like we've had cases where the mom had a double mastectomy for breast cancer. In those cases, you really don't want a bunch of providers walking in the room and saying, well, why aren't you breastfeeding? You don't want to have to tell that story over and over. So I would advise you come up with some way of letting people know when it's not appropriate to talk about breastfeeding.
I think the big thing here, again, with the step 6 is what starts becoming the norm and what starts becoming the culture on the mother-baby unit. And I think this really applies, and also because the culture shifts, then even the expectations of the pediatricians, of the inpatient pediatricians, or whoever is seeing babies on the, new babies on the postpartum floor, it's not as easy for them to just implement formula for babies. They have to then be able to justify it and explain it to the nurse, because the nurse needs a reason in order to put it in the computer and stuff. So there are some steps that make it less of, I think, a knee-jerk response to prescribe formula. Step 7 is what we call rooming in. And this means that you allow moms and babies to be together 24 hours a day. When we implemented this in Presbyterian, the newborn nursery got deleted. We no longer have a newborn nursery. We have a NICU, but we have no nursery. So babies stay with moms unless they have critical issues, and then they go to the NICU. And that was something that we had to make sure to tell patients about ahead of time, because they are surprised when the expectation is that the baby will stay with them the entire time, sometimes unpleasantly surprised. But for the most part, I think the response to this from the patient side has been a lot of satisfaction, again, in not having the baby being taken away. But there's probably more pushback, I would say, from the pediatricians from this, because it's a lot easier to round on a bunch of babies in the nursery than it is to go from room to room and have to deal with parents. But after some deliberation, this practice, and that was part of, getting rid of the nursery, means there just really isn't that option anymore at Presbyterian. But it does, I think it does require some explaining to the patient in the prenatal time period, so that they're not surprised that the baby stays with them.
Did you guys experience any pushback from administration in terms of changing around your floor, like logistics of getting rid of this whole nursery and then having more rooms, or was there any of those conversations with administration? In terms of shifting?
I don't remember specifically about the use of the space. I wasn't involved in those conversations with Presbyterian, unfortunately. So I couldn't comment on that.
Yeah, and we've retained our nursery because certain things are still done in the nursery, like we do the circumcisions there. We don't do circumcisions in the baby's room. And we actually will have some cases where, for instance, the baby's been removed from the parent's custody, and so they may be in the nursery, and there may be cases where there's actually a baby staying overnight. So we have retained our nursery, but it's pretty darn empty. And we'll talk a little bit more about rooming in later.
Yeah.
Oh, okay, we're talking right now. I couldn't remember if it was now or if it was later. So this is my slide. This is Dr. Spesta, and I love sleep. I have 4 children, and I don't sleep enough, so I really like sleep. And so I've always been really interested in this topic. And studies show again and again and again that moms who room in, moms who keep their babies with them all night and breastfeed them all night actually get more sleep than moms who do not. So, for instance, this first study looked at 120 low-income, so this is not just well-to-do moms who have a lot of help in the house, so low-income, ethnically diverse, and found that at 1 month, if they were breastfeeding exclusively, they got 30 minutes more of sleep than moms who used formula. And I think part of this, well, let me go to the next study, and then I'll say why I think that is. Another study looked at the same question, and it compared mothers who were exclusively breastfeeding all night with mothers who were giving formula with controls. So people who did not have a newborn, okay, so just don't have a baby at all. Then they got 2 to 3 times as much of the stage 4 deep restorative sleep. And this is the sleep that makes you feel rested. And there's plenty of studies that also show that the moms actually feel more rested when they actually breastfeed the baby all night, which is kind of, I think, people are surprised by this. They think, oh, if my partner feeds the baby all night, I'll get more sleep. But you don't, and I think the reason is twofold. One, prolactin is a really powerful, puts you to sleep. Okay, so after you breastfeed, you just go right back to sleep, no problem at all. Versus you get woken up by your baby crying because they're hungry. Somebody else feeds the baby, and now you are awake. I also think that this is kind of from an evolutionary standpoint, this makes sense. We would not have survived as a species if women were so exhausted breastfeeding their children all night that they could not function, right? We just wouldn't be here today. So this is in many ways not a surprise to me. And the advice that I give to moms, on top of saying really don't shoot yourself in the foot by having somebody else feed the baby at night, is whenever the baby's asleep, if possible, you should be asleep. And I try to say this in front of any other people who are in the room. I like to say it in front of dad. I like to say it in front of the maternal grandparents or everybody, and say, you should be asleep when the baby's asleep. You just ran a marathon. You were pregnant, and now you're climbing a mountain, and now you're about to run another marathon. And so you really need this sleep. And the babies sleep a lot, so you can get away with it. It's harder if you have other children when you're single.
The other advantage to rooming in is that the moms learn feeding patterns. And one of the sayings to help educate about this step is 8 or more in 24, which is probably old news to some of the lactation people we're talking to. But as opposed to my baby has to eat every 2 to 3 hours, 8 or more in 24 helps them understand signals for breastfeeding before the baby's a crying mess, and understanding that cluster feeding patterns are common. So there's a lot of education for the mom also, I think, that happens by rooming in with the baby as well.
Just the same thing. I just like sleep. We can move on.
There's the 8 or more in 24. Sorry. So this is step 8, encourage breastfeeding on demand, which means, the part of the Baby Friendly Hospital Initiative is to allow babies to eat when they're hungry and when they're ready, and to show moms what that looks like, and that is not necessarily an every 2 hour and every 3 hour pattern. Most of the time babies are, they have that first hour, they breastfeed in that first hour. Many babies will breastfeed well in that first hour, even though they're only getting a few little drops of colostrum, and then they conk out for a while. And moms are always freaked out because my baby's not eating. And then I say, don't worry, you're going to be up all tomorrow night because of the cluster feeding pattern. So this is just something, I think, again, that's part of empowering moms and educating moms about how to recognize the signals from the baby.
And this is intuitive for a lot of moms, but for a lot of moms it's not. So like I had a mom today, and we were talking about it. I was like, oh, look, I think she's hungry because she's sticking her tongue out, and and she's putting her, and the mom said, oh, does that mean she's hungry? Yeah. So people, I think, are kind of programmed, through the media, through what they've grown up with, to think that when the baby is hungry, the baby cries, but actually crying is a late sign of hunger. And that's a really important message to send to parents, because when the baby gets to the point where they are crying, sometimes it's hard to get. They don't have good control. They're not very good at monitoring their kind of states of being. And so it's very hard for them to organize their little bodies and breastfeed at that point. So you really want to help. So my advice is, like, when you go in the room and you see the baby doing some of these things, say, oh, look, your baby's hungry, and really try to help them to clue into that.
I'm just going to keep moving along so we
Yeah.
get on time here. Sorry. Step 9 is give no pacifiers or artificial nipples to breastfeeding infants. And again, this is another one of those things that seems to come into play mostly on the mother-baby floor, but also this correlates with the Baby Friendly Hospital Initiative will also require that any advertisements for pacifiers, artificial nipples, and formula all be eliminated from the hospital and from hospital-associated clinic areas. There's, I think there are at some facilities, again, we don't do the circumcisions, but I know that there are some situations where sometimes a pacifier is given, for a circumcision or certain situations like that. But again, this is a shifting of the culture from what is considered normal to what is considered the exception to the rule. And this was one of the things that we saw at Presbyterian happen, that instead of the norm being pop a pacifier in the baby's mouth when it's crying, the norm is to watch for the hunger cues, feed the baby, and sometimes, avoid those crying episodes. But giving the pasta to the baby just isn't the norm on the floor anymore.
But of course there are exceptions. So when you're circumcising the baby, put a pacifier in their mouth, dip it in sweeties, and then throw it away when the circumcision is over. And of course in the NICU, premature babies who have neonatal abstinence syndrome, we have a lot of those babies, they need their pacifier. And that's not a problem for Baby Friendly. And then babies who are under phototherapy as well. Although you can do family-centered phototherapy, but we won't talk about that now. That basically just means you put baby on mama's chest, and mama and baby both have cool sunglasses.
Yeah. Mom gets a little tan. And finally, the final step, step 10, is to foster the establishment of breastfeeding support groups and to refer mothers to them on discharge from the hospital or clinic. You're trying, with this step, I think the Baby Friendly Hospital Initiative is really trying to help and to point hospitals and clinics towards the postpartum period. Most of the steps in this to baby friendly are really not geared towards postpartum time period, but this is the one step that I think does say you need to have some sort of support system in place for moms when they leave the hospital.
And just a quick note about this is this does not mean necessarily that you have to literally refer mothers to support groups for breastfeeding. This can be the 2-day follow-up for newborn clinic to check on breastfeeding. This can be lactation clinic. This can be peer support counselors. This can be a lot of different things. It just essentially means you want to have that support network out there and that safety net, because one thing that baby friendly hospitals, for instance, when up in I think it was Farmington or San Juan Regional, they essentially went baby friendly like 15 or 20 years ago, and they neglected step 10. And what they found is they had a whole bunch of babies coming back in for readmission with jaundice and dehydration. So this is really, really important. And it means, especially with your first time breastfeeding moms, you really want to watch them closely and see them back to make sure that they're not getting into trouble. I'll talk about it. So this is the International Code of Marketing of Breast Milk Substitutes, and you have to comply with this. And this is fascinating because, and we already said what it is. So you don't promote formula, bottles, breast milk substitutes, and you don't give out free samples, and you can't have American Baby sitting in your waiting room anymore because it has lots and lots of advertisements for formulas. You have to be very careful. But this was an international, almost like a treaty, and 84 countries have enacted. And of course, the United States being the United States, we are one of 16 countries who have not actually enacted this, and we are in the proud company of the Central African Republic, Somalia, Kazakhstan, Equatorial Guinea, and my personal favorite, North Korea, which is just to show that the rest of the world does this differently, and we can do better in the United States.
And these are some of my slides about the media and about why you have to be so careful with this international code. Not careful with the code, but careful to be in compliance with the code, because there are millions and millions of dollars invested in breast milk substitutes, and these companies don't want you to take their advertisements out of clinic and out of magazines. And so there's a lot of very sneaky advertisements and marketing that are out there for formula, basically, but other substitutes as well. This is my favorite, and I don't know if anybody has seen this online, but it's called the Mother quote Hood, as in like gangsta hood, official video. You can get it on YouTube, and if I could figure out how to hook up a video link, I would. But in this commercial or this YouTube video, what they have essentially done is it's this very kind of witty play, and it's actually very funny to watch it. But it has to do with all these different groups meeting on the playground, right? So there's and it plays on the stereotypes. There's like the super hippie breastfeeding group who are like frowning down at all the moms that have bottles. They're like, oh my God. And then there's the yuppie in their suits, moms who are the stereotypical career woman, and they're frowning down at the hippie moms. And there's the stay-at-home dad group, right? And they've got all the baby Bjorns bundled on there, and they're bottle feeding their babies. And so it's like this throwdown in the playground, right? All about how between these different feeding groups. And the take-home message that they want you to have is, don't be judgmental of how your peers or whatever are breastfeeding their babies. Stop
feeding their babies.
Feeding their babies. Stop the judgment, right? And I thought this was really funny, and I thought, well, who made this video? Well, it turns out Similac made this video because they don't want judgment. I mean, the hidden message there is not to be critical of bottle or formula, I should say, formula-fed babies. Is not to be critical of formula-fed
Well, the
babies.
hidden message is that breastfeeding and formula are equal.
Right.
And they're not.
And they're not. And there's a lot of sneaky media out there that I think and this
is the kind of thing that gets shared on Facebook, so lots of people see.
And when I was watching, and this came out about a year ago or so, and you see it go very viral, and there are a lot of comments that are like, yeah, way to go, Similac, like as if this is very empowering to women. And I'm thinking, boy, this is one of the sneakiest pieces of advertising that I've seen in a long time. So I just say beware, because these companies have a very vested interest in making breastfeeding and formula feeding seem equal, and to make people who are promoting breastfeeding seem kind of evil in a way, because we're supposedly passing judgment. And I think there's a lot of money being put into this, and so I'm just saying that the marketing is sneaky, and you will find it in all kinds of crazy hidden places in your clinic when you start looking for it. And my other take-home message from this was that I think I even, inadvertently say bottle feeding, when I don't think that bottle feeding necessarily has to equal formula feeding either. Mm-hmm. And so I've been trying to get away from that language too. But there are some significant dangers, or I should say risks, to formula feeding. And I put this up there. I say, okay, it's not the devil. And I compare it, for if there are any obstetric providers in the audience, people see, many of my patients think Pitocin is the devil, right? And even though Pitocin actually probably saves thousands of mothers' lives from postpartum hemorrhage. But I want, my thought again is to stop making formula become the norm, or the knee-jerk prescription, or the knee-jerk cure for feeding issues. And I think if you think of it in the same context as you would think of any other medicine, really, I mean, even an over-the-counter safe medicine like ibuprofen is not safe if you take too much of it. It has certain risks. You can't take it if you have kidney disease, blah, 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 blah. You really have to look, whenever you take a medication, and anybody who's been trained in whatever medical capacity will know that whenever you take a medication, you really have to weigh the risks and the benefits to any medication. And I think if we thought about formula in the same way and started weighing the risks and benefits, then we would understand that there are certain contexts when it is absolutely important, and it is critical, and it saves lives. And there are other contexts where it is not, and it will do more harm than it will good.
And I'm just going to reflect real quick on the increased risk of gastrointestinal diseases, especially necrotizing enterocolitis. So there's some really nice studies that show that it takes the number needed to treat, so the number of babies that need to receive exclusive breast milk who are premature to prevent one case of surgical neck or death is 8. It's a very small number needed to treat. And the hypothesis is that the formula, the bovine protein, the cow's milk protein, actually causes inflammation, which leads to kind of a leaky gut, which then leads to neck. So it's not so much the absence of breast milk as it is the formula itself is dangerous. And we have to recognize we are giving kids something that really isn't what they were meant to get.
Okay, let's see, and we have about 15 or so minutes. So some of this is again, this is geared towards providers, and questions that come up are, why should I care about this? I have so many other things I'm trying to do in clinic and squish it all in. Like, why does this need to be a priority? And part of what we want to impart on people today is, number one, there is, and I can't really emphasize this enough, but there is a ton, like literally hundreds of studies. This is a very well evidence-based practice that shows that breastfeeding is the cornerstone of preventative medicine, that it prevents very, very, very many illnesses in children, but even things that trickle down, such as obesity and diabetes, and really overlap into adulthood. So in my
and also for the mothers.
And also for the mothers, for both moms and babies, that breastfeeding is such a cornerstone of preventative medicine. And this is a hugely, very well, this is well established by the medical literature, I should say. I just don't necessarily think it's as well known in medical practice as it is well established in the medical literature. And the other thing is that many, many patients want baby-friendly practices. And so now that we're in a medical system that is starting to weigh more heavily about patient satisfaction and the ultimate patient experience, we know, and we're going to show you some numbers here in just a minute, that 80% of mothers intend to breastfeed their babies. And if you have a system in place that helps them do that, that will increase your patient satisfaction scores. You want to?
Yeah, this is just some of the breastfeeding benefits for a baby. I'm not going to belabor this. I think all of you guys know this, okay? It helps to prevent lots of things, or reduces the risk rather, including SIDS and cancer, which is not always so well known. And then of course the breastfeeding benefits for mom, just decreased postpartum hemorrhage, bonding, stress reduction. And the things that are really interesting to me is, for instance, the breast cancer and the ovarian cancer, that is very much dose dependence, especially with breast cancer. So for every year that a mother breastfeeds, her risk of getting breast cancer premenopausal goes down by 4%. So I breastfed 3 kids for a total of 8 years. I decreased my risk by 32%. Boom. That's just that easy. It also decreases mom's risk for type 2 diabetes and cardiovascular disease, so high blood pressure, etc.
I will tell you the big seller is the weight loss.
Yeah.
If you're trying to sell breastfeeding in your clinic, you can tell them what an effective way it is to lose all that baby weight.
Yeah. And it saves lives. We know this. I think probably you guys have all heard this, that if we exclusively, women exclusively breastfed for 6 months, we'd save 1.5 million lives worldwide. And in the United States, we have a lower threat. We're not that ambitious. So say 90% for 6 months, 911 lives, and $13 billion. That's a lot. And that's just considering the babies. That's not considering the mothers. And individual savings, $750 to $1,200 per year. And for WIC moms, this is super important because this is not well known. If a mother qualifies for WIC, which I think is most of our patient population, it's not going to pay for 100% of the formula that baby gets in the first year of life. So great examples, I saw a baby last week in clinic with one of the residents, and they were giving cow's milk at, I think it was 9 months of age. The baby might have been younger, I can't remember, because their formula wasn't going far enough because WIC wasn't providing them with 100%. So their idea was, let's give cow's milk. I've seen other families just water down the formula. These are dangerous things to do. And parents don't know that. They think, oh, it's free, but it's not free. You're going to pay $700 to $1,000 out of pocket. And then of course we know that breastfeeding is going to save millions of dollars a year in a variety of venues. And it's good for business, $2 to $3 for every $1 investment. So we need to get the message out there too. So what do the experts recommend? And you can see that there's a long list, and I won't tell you who they are, but everybody says at least 6 months exclusive breastfeeding. So no water, no formula, no solids. And then to continue to breastfeed for at least 1 to 2 years. And this, I think we should all be telling our patients. And then to continue as long as mutually desired. So I will tell parents, if they're willing to listen, yeah, we want you to do exclusive for 6 months, and we want you to go for a year. And then if you're done, fine, you can be done. On the other hand, if you like it, I highly recommend 2 to 4 years. I mean, there's actually some really nice benefits that start accruing as you get closer to that 3 to 4 year, like decreased obstructive sleep apnea and jaw and mouth formation for the babies. And then of course for the moms, that decreased risk of breast cancer. But we have to be careful, because I think a lot of parents, what they hear when we say 6 months exclusive breastfeeding is they hear breastfeed for 6 months. And there are practitioners out there who will tell people, you need to stop, your baby's 6 months old. So again, we have to be careful with our message, and everybody says this is the way to go. So what does the evidence say about baby-friendly practices? So getting back to those 10 steps for successful breastfeeding. The effect is dose-dependent, much like the breastfeeding on the mom's cancer. And the odds ratio is from 1 to 2.7 with each additional step. So I'm going to show you a nice graph. Actually, I'll get to the nice graph in a minute. So actually, I'm going to go on to the nice graph. Okay, so if you have 0 steps in place, oh, can I use it? Hey, look at that. Oh, it doesn't work. It doesn't work. Okay, just look at 0. Okay, if you have no baby-friendly practices, oh, thanks. If you have no baby, it's okay. If you have no baby-friendly practices, you have a 32% chance of stopping breastfeeding by 6 weeks of life. And this is for mothers who intended to breastfeed. For each step that you add, that risk of stopping breastfeeding way before you wanted to goes down, dose dependent. Okay, so it really does matter. And I'm going to go back real quick just to say the biggest risk factor for early cessation of breastfeeding is late breastfeeding initiation, so not the first hour. Okay, so keeping mom and baby separated, and formula supplementation. Formula supplementation. This is the one that people have a really hard time with, and if many moms want to get formula and everybody thinks it's no big deal, it kind of is.
And it's particularly, and I would just say this is particularly a big deal during, I'd say, that first week, but those first 4 days or so, because the hormones are changing and are adjusting in mom. So all of the receptors are being built during those first 3 to 4 days as mom's switching over to colostrum and her milk is coming in. That's like a crucial time period. If you start formula supplementing there, mom's not even going to make the right number of receptors in order to generate the milk supply that she would need for that baby. So it's really important, even in those first few days, I really try to emphasize to my fellow providers, but also to my patients, to try to stay away from formula during those first few days.
So,
so this is the latest, since we're talking about evidence-based here, this is the latest publication from the U.S. Preventive Service Task Force, and it was published in JAMA just this past October, and they did a huge systematic review, meta-analysis on primary care interventions to support breastfeeding. And they looked at individual-based interventions, and they looked at system-wide interventions. And the overall recommendation that they found was that, they found moderate level B evidence saying that there is more benefit than harm, and that breastfeeding and that breastfeeding interventions should be implemented. So again, this is a big study looking at lots and lots of trials, 43 trials that were looked at, showing a higher likelihood of any breastfeeding at the 3-month time period, and then also at the 3 to 6 month time period compared to usual care.
Well, actually, it showed a higher association of both exclusive and anti-breastfeeding, so both.
Right. So, and again, this is one of those, I put this slide in because this is one, if you're looking for evidence-based stuff, this is as good as it gets in the medical literature. When you have a big systematic review like this by the USPSTF, this is like something in the Cochrane database. This is as good of evidence that you can get. And when you have them say that there is a net benefit to breastfeeding interventions, it means that's just what that's I don't know how else to say it.
We just need to do it, and
you have to do it.
It also talked about how a single intervention is not nearly as effective as multiple, i.e. systemic interventions. And so, again, something like a baby-friendly hospital initiative, which is really a bunch of different interventions all together in a systematic way, is going to be far more effective than just having your prenatal providers provide education to mom, or just having the baby go skin to skin after birth. And it's kind of like the graph we showed earlier, that the more you have, the better effect you get. And I actually loved how, and this was Sophie's slide before, if you go back, the number needed to treat is 30. So for every 30 women who are offered this kind of support, one additional woman is going to breastfeed for up to 6 months. Number needed to treat of 30 is really, really good. I think like the number needed to treat for cholesterol lowering medication is like in the hundreds, if not thousands. Right. Like it's ungodly. I mean, you wonder why we even do it. This is actually a nice small number. So
and somebody told me, and maybe you can comment, this number needed to treat equal to 30. This is kind of close or in the range of where they start recommending childhood vaccinations. It's like, that's where your child, which we routinely recommend, right? Childhood vaccinations to prevent measles and to prevent rubella and stuff, because the number needed to treat is in this range, around 30. So just to give you an idea of how useful breastfeeding is and what really an awesome preventative tool it is, this is the evidence that gives us, that supports that.
Well, it supports that we need to help.
That we need to help. It supports intervention.
So I'm going to move on. So people want baby-friendly hospital practices, okay? As we were talking about earlier, 75–80% of women initiate breastfeeding. This tells us they want to breastfeed, okay? And it's our job to help them to breastfeed. So this is just one study that showed over time how many women are initiating breastfeeding, and it's just going up. And we did a focus study with the New Mexico Breastfeeding Task Force, and it oversampled for Latino mothers, or Latino people rather, because that's what our population is largely made up of in New Mexico. And once people were told what baby friendly was in a pretty simple way, 91% favored it, and 95% thought it was important. So this included men, this included people who've never had babies, this included people who formula fed, this included the population as a whole. So why else is this important? Well, there's an epidemic of failure, right? So we already established most women want to breastfeed, okay? They usually have a plan for how long they want to breastfeed, like that 6 weeks or 6 months. And most women stop breastfeeding earlier than they planned, okay? And this is a fact. And many, many, many of these women feel guilty, okay? And that's one of the reasons why the advertisement or the YouTube video was so successful, because it's saying, oh, stop judging women. But this isn't about blaming women. This is about saying, hey, wait a minute. This is what women want to do. What do we as a society need to do to support them? This isn't about making individual women feel guilty. This is about supporting them. So one of the tactics I have when I'm talking to moms who maybe either didn't breastfeed their previous children, breastfed them for a very short time, or whatever, or the grandparents, the grandmothers, is to say, the first words out of my mouth are, I am so sorry we did not give you the support you needed when you had your first child, or when you had, this as a grandma, when you had your child. We are going to do better. We are working really hard to give you the support that you need. And to really take the blame away from the individual, because it really isn't an individual's fault. So here's a study from 2012, 85% of moms wanted to exclusively breastfeed, and only 32% met their goal. So what happened? Well, this is a complicated slide. Suffice it to say, half of it was latch, half of it was supply. And when we say supply, we're not talking about real supply. We're mostly talking about perception. So how the number? Well, I would ask you if we were in an interactive, I would say, how many moms really can't breastfeed sustain their baby growing healthily for 6 months with exclusive breastfeeding? The number is less than 5%. So less than 5% of women truly cannot exclusively breastfeed their baby for 6 months. How many moms think they can't make enough milk? Just guess, Courtney.
Well, yeah, let's see.
Over half. Over half. So over 50% believe they're not going to make enough milk, period, at all. And truly, it's way less than 5%. And they feel rotten. They feel bad when they don't succeed. So it's our job to help them to succeed. And we have to be really careful, because we are looked up to, and people really do respect physicians and nurses and medical students. And if we kind of come across like, oh, it's not that big of a deal, that's what they perceive. And unfortunately, like so many things, one negative comment has way more power than 10 positive comments. So one person walking into the room and saying, oh, I guess your baby's not getting enough, or something along those lines, or gee, maybe you should, try supplementing, or, oh, you're not doing that right, just totally turns them off. So we have to be supportive, and we have to be careful about the words that we use and the actions we take. So again, why is it our job? Well, prenatal providers, I don't have access. Thank you, Sophie. We care. It's good medicine. It's evidence-based. And then for those of us after the fact, we need to help moms succeed. And we don't intend to not support breastfeeding, but we often do this without meaning to. And we have to be really careful to not make moms feel guilty. So, and this is an art. I have residents and medical students ask me all the time, and there is no perfect way to know when you hit that line where you're no longer supporting and now the mom feels pressured or harassed or coerced. And you have to just learn to recognize that line and say, okay, we're done. I'm not, I don't want to make you feel bad, but it's just something, you get better at with time. But the systemic changes really help. If we can give women the support way earlier, you can have less of these women ultimately saying, no, yes, sufficient, I'm done, I don't want to breastfeed.
And I think, yeah, so I'm going to go through these slides fairly quickly, because we did want to leave some time for questions and stuff. But in order, learning how to judge that line, like you're saying, has to do a little bit with this tricks to the trade. A lot of these next following slides are really geared at prenatal providers, and I'm not sure exactly how many of them are in our audience exactly today, although I know that this is, going to be logged on the website for later. But The take-home message here is that you don't have to be brilliant. You don't have to be a lactation consultant. You don't have to have any really super special training in order to promote breastfeeding in your clinic in the prenatal, even in the prenatal time period. All you really have to do as a provider is you have to say it, and you have to believe it, and you have to say it. You say that this is important, and guess what? Patients really respect your decision. So my take-home message about how do you promote breastfeeding in your clinic, the first thing I say is you just say it. You just say, are you breastfeeding? Have you thought about breastfeeding? Think about breastfeeding. Breastfeeding is great. Those kind of words, that type of encouragement, that's the very, very first line. It's probably the best thing you can do as a provider, because that is the take-home message that patients need to hear. Once they hear that you're encouraging it, that this is a good thing, the other pieces can fall into place. One of those pieces is to utilize resources, and most of us, if you are my age or older than, and you're an MD, you probably didn't get any training in breastfeeding. This is sort of a new thing that's coming through some of the residency programs now. And I think that because we're not always super comfortable with it, because we didn't get, quote, trained in it, we don't promote it because it's unfamiliar territory. And again, my take-home message is you don't have to be a lactation expert. It's great if you know one. And if there's it's great if there's one in your community. And if there's not, I would say utilize your other statewide resources. They are there. But the take-home message for the prenatal provider is just to say it. These are some of we'll kind of go through these, some of the things that say before and after. But again, I think if you say it and you utilize your resources, those are the two key things to the prenatal education. Some of the finer points are then you get into the trimester specific education. There are some tricks to the trade as far as utilizing the electronic medical record that can decrease the clinic time, decrease the amount of clinic time that you are required to dedicate to this in order to pass baby-friendly designation. And also, I encourage all prenatal providers to get some basic breastfeeding training.
That applies to the pediatricians too.
And pediatricians as well, right. I think the slide that we had up earlier that shows that the majority of moms give up breastfeeding because of a latch issue or because of a perceived supply issue. Those two things can be solved usually with minimal intervention. It doesn't always require a highly trained lactation consultant to adjust some of the very basic things with both latch and some education about supply. And so I would encourage some basic training. And the other thing I always say is don't give up on your patient. If a patient really wants to breastfeed, please help them find the resources. Don't give up, because I think that's what happens. And people prescribe formula because they've given up and they've run out of ideas.
Especially as pediatricians, because it takes time to have these conversations.
Mm-hmm. That's some of the trimester specific stuff. We can kind of go through these things.
We're time, aren't we?
Right.
Okay.
I think that's it. That's the last slide. So we can take questions. Or not.
And you can use the chat box as well if you are unable to unmute.
No questions?
We have a thank you.
We might have to go back and do some more slides then. No questions.
Maybe then we'll just put out there that through Envision New Mexico and through the New Mexico Breastfeeding Task Force, if you guys come up with questions or if you're looking for extra help, that Emily and I are both available to either answer further questions, but also both of these groups have a lot of resources for people who are not even here necessarily in Albuquerque, but I've been amazed with working through the task force at the statewide connections that there are and the statewide resources. So for anybody who's calling in from out of town or who might be looking at this at a later date and wondering what they can do in their clinic practice, I would encourage them to visit the New Mexico Breastfeeding Task Force website. And to check out the long list of resources that are available there.
I'm going to just say two real quick things. One, WIC peer counselors, WIC peer counselors, WIC peer counselors. We have one of the best peer counselor programs in the country. So states around the country look to New Mexico because our WIC peer support counselor is so effective. So if, especially for your moms who don't have a lot of resources or maybe speak Spanish, this can be tremendously helpful. And the WIC peer counselors are typically available, I want to say 24/7, because it's not just during daylight hours. And I think mothers really do find this helpful. Another thing is, one of the lactation specialists I love the most told me in the last couple months is, when she first started out, she was very like, okay, you have to position this way, and the baby has to be this way, and kind of more like, this is how you do it, prescriptive. And she says, as time has gone by, she's learned really 3 things you care about. Is mom comfortable? Is baby comfortable? Is baby feeding effectively? So if mom is comfortable, baby's comfortable, and it's working, leave it alone. And you can help adjust a little bit, like, oh, that lip is turned under, let's help get it out. Or, gee, baby's got to turn their entire neck to breastfeed, that's not going to work, let's help a little bit. But beyond those kind of main things, a lot of it's just saying to mom, if it's hurting, pop that baby off and try again. And just help that mom to just kind of get to what her sweet spot is. And it may not be what worked best for you or some other mother. So that's it.
And I just want to say, through this initiative, as we launch the QI initiative into the hospitals and the outpatient clinics, Sophie and Emily are going to be great resources. As Sophie said, they're available to you guys, and they are closely involved in the QI initiative as we move forward. So if you guys ever have any other questions or comments as you either implement your baby-friendly process or just want to improve the care or support that you give to mothers, we'll keep eyes on that, and feel free to contact us.
How do we access the handouts?
Oh, you can, this is Kevin. If you go to our calendar where you registered for the session today, the handout should be downloadable there in a PDF form.
Okay, thank you.
You're welcome. Anything else?
Thank you so much.
Thank you, everyone, and thank you, doctors.